Hello students, today we will discuss about prenatal diagnosis and our main objectives will be to give a brief introduction of prenatal diagnosis, to study about the indications of prenatal diagnosis, to study about the methods of prenatal diagnosis, to study in detail about the non-invasive and invasive techniques of prenatal diagnosis, and to study about the pre-implantation genetic diagnosis. So, first and foremost, an introduction about the prenatal diagnosis. 30 years ago, fetal medicine did not exist and the fetus concealed in the uterus was a passenger rather than a patient. During the last 3 decades, owing to the development of cardiotocography, ultrasound, Doppler imaging, sampling techniques, biochemistry, genetics, and molecular biology, a considerable amount of knowledge has been accumulated, allowing a more precise definition of fetal physiology, anomalies, and diseases. The fetus has thus become a patient that we can diagnose, follow, and treat. Prenatal diagnosis, traditionally used as a synonym for invasive fetal testing and evaluation of chromosomal constellation, presently encompasses many other issues like pedigree analysis, fetal risk assessment, population screening, genetic counseling, and fetal diagnostic testing as well. Prenatal diagnosis is important in detecting and preventing genetic diseases. Coming to our second objective, that is to study about the indications of prenatal diagnosis. Prenatal diagnosis occasionally allows prenatal treatment to be instituted but is generally performed to permit termination of pregnancy when a fetal abnormality is detected, or to reassure parents when a fetus is unaffected. Since an abnormal result on prenatal testing may lead to termination, this course of action must be acceptable to the couple. Careful assessment of their attitudes is important, and all couples who elect for termination following an abnormal test result need counseling and psychological support afterwards. Couples who would not contemplate termination may still request a prenatal diagnosis to help them to prepare for the outcome of the pregnancy, and these requests should not be dismissed. Pregnancies at risk of fetal abnormality may be identified in various ways. A pregnancy may be at increased risk of Down syndrome or other chromosomal abnormality because the couples already have an affected child because of abnormal results of biochemical screening or because of advanced maternal age. There is a high risk of a chromosomal abnormality in the fetus when one of the parents is known to carry a familial chromosome translocation or when congenital abnormalities have been identified by prenatal ultrasound scanning. In other families, a high risk of a single gene disorder may have been identified through the birth of an affected relative. Several important factors must be carefully considered before prenatal testing, one of which is the severity of the disorder. Screening tests aim to detect common abnormalities in pregnancies that are individually at low risk and provide reassurance in most cases. There is widespread application of routine screening tests for Down syndrome and neural tube defects by biochemical testing and for fetal abnormality by ultrasound scanning. Coming to our third objective, that is to study about the methods of prenatal diagnosis. Prenatal care is a significant step which helps to prevent complications and inform mother about the important steps that she can take to protect her infant and ensure a healthy pregnancy. To analyze the health and condition of an unborn fetus and to reduce the risk of pregnancy-related complications, prenatal diagnosis is done, which employ a variety of techniques. Prenatal diagnosis involves testing the fetus before birth to determine whether the fetus is in a fit condition or has certain abnormalities, carries hereditary or spontaneous genetic disorders, and complications of diabetes. Two types of techniques are applied for prenatal diagnosis: non-invasive and invasive techniques. Non-invasive procedure is harmless to both the fetus and the mother, used during specific time periods during the pregnancy, and includes ultrasonography and maternal serum diagnosis, that is alpha-fetoprotein. Invasive method involves probes or needles being inserted into the uterus but may be risky to the fetus, which include techniques as amniocentesis, chorionic villus sampling (CVS), chordocentesis, and fetal blood and tissue sampling. Coming to our fourth objective, that is to study in detail about the non-invasive and invasive techniques of prenatal diagnosis. First, we will discuss about non-invasive techniques. First one is maternal serum screening. Estimation of maternal serum alpha-fetoprotein AFP concentration in the second trimester is valuable in screening for neural tube defects. A raised AFP level indicates the need for further investigation by amniocentesis or ultrasound scanning. In some centers, amniocentesis has been replaced largely by high-resolution ultrasound scanning, which detects over 95% of affected fetuses. In 1992, a combination of maternal serum, AFP, alpha, human chorionic gonadotropin HCG, and unconjugated estrol UE3 in the second trimester was shown to be an effective screening test for Down syndrome, providing a composite risk figure taking maternal age into account. Serum screening for Down syndrome is now in widespread use, and diagnostic amniocentesis is generally offered if the risk of Down syndrome exceeds 1 in 250. Screening strategies include combinations of first trimester measurement of pregnancy associated plasma protein A and HCG, second trimester measurement of AFP, HCG, UE3, and inhibition A, and first trimester nuchal translucency measurement. The isolation of circulating fetal cells such as nucleated red cells and trophoblasts from maternal blood offers a potential method for detecting genetic disorders in the fetus by a non-invasive procedure. This method could play an important role in prenatal screening for aneuploidy in the fetus, either as an independent test or more likely in conjugation with other tests such as ultrasonography and biochemical screening. Second one is ultrasonography. Ultrasonography is a form of body imaging using sound waves to facilitate medical diagnosis. Ultrasound produces sound waves that are beamed into the body, causing return echoes that are recorded to visualize structures beneath the skin. Obstetric indications for ultrasonography are well established and include confirmation of viable pregnancy, assessment of gestational age, localization of the placenta, assessment of amniotic fluid volume, and monitoring of fetal growth. Ultrasonography is an integral part of amniocentesis, chorionic villus sampling, and fetal blood sampling, and provides evaluation of fetal anatomy during the second and third trimesters. Disorders such as neural tube defects, severe skeletal dysplasias, abdominal wall defects, and renal abnormalities may all be detected by ultrasonography between 17 and 20 weeks gestation. Centers specializing in high-resolution ultrasonography can detect an increasing number of other abnormalities such as structural abnormalities of the brain, various types of congenital heart diseases, clefts of lip and palate, and microphthalmia. For some fetal malformations, the improved resolution of high-frequency ultrasound transducers has even enabled detection during the first trimester by transvaginal sonography. Other malformations such as hydrocephalus, microcephaly, and duodenal atresia may not manifest until the third trimester. Abnormalities may be recognized during routine scanning of pregnancies not known to be at increased risk. In these cases, it may not be possible to give a precise diagnosis. The abnormality detected, for example, cleft lip and palate, may be an isolated defect with a good diagnosis or may be associated with additional abnormalities that cannot be detected before birth in a syndrome carrying a poor diagnosis. Now coming to invasive techniques. First one is amniocentesis. This method was first performed as therapeutic procedure more than 100 years ago for decompression of polyhydramnios. Amniocentesis became a diagnostic procedure in 1950s when Davis first used amniotic fluid for measurement of bilirubin concentration and prediction of the severity of rhesus immunization. Today, amniocentesis is a significant diagnostic tool for prenatal detection of chromosomal as well as metabolic disorder. Tests performed on fetal cells found in the sample can reveal the presence of many types of genetic disorders, thus allowing doctors and prospective parents to make important decisions about early treatment and intervention. It is usually performed at 15 to 16 weeks gestation but can be done a few weeks earlier in some cases. It is reliable and safe, causing an increased risk of miscarriage of around 0.5 to 1%. Amniotic fluid is aspirated directly with or without local anesthesia after localization of the placenta by ultrasonography. The fluid is normally clear and yellow and contains amniotic cells that can be cultured. Discoloration of the fluid may suggest impending fetal death. The main indications for amniocentesis are for chromosomal analysis of cultured amniotic cells in pregnancies at increased risk of Down syndrome or other chromosomal abnormalities, and for estimating alpha fetoprotein concentration and acetylcholine esterase activity in amniotic fluid in pregnancies at increased risk of neural tube defects, although Few amniocentesis are now done for neural tube defects because of improved detection by ultrasonography. In specific cases, biochemical analysis of amniotic fluid or cultured cells may be required for diagnosing inborn errors of metabolism. Amniocentesis is recommended for women who will be older than 35 on their due date. It is also recommended for women who have already born children with birth defects or when either of the parents has a family history of a birth defect for which a diagnostic test is available. Second one is chorionic villus sampling. The ability to sample and analyze villus tissue was demonstrated in China in 1975. Chorionic villus sampling is a technique in which fetally derived chorionic villus material is obtained transcervically with a flexible catheter between 10 and 12 weeks gestation or by transabdominal puncture and aspiration at any time up to term. The risk of miscarriage related to sampling in the first trimester in experienced hands is probably about 1 to 2% higher than the rate of spontaneous abortions at this time. Dissection of fetal chorionic villus material from maternal decidua permits analysis of the fetal genotype. The main indications of chorionic villus sampling include the diagnosis of chromosomal disorders from familial translocations and an increasing number of single gene disorders amenable to diagnosis by biochemical or DNA analysis. The advantage of this method of testing is the earlier timing of the procedure, which allows the result to be available by about 12 weeks gestation in many cases, with earlier termination of pregnancy if required. These advantages have led to an increased demand for the procedure in preference to amniocentesis, particularly when the risk of the disorder occurring is high. Third one is chordocentesis. Chordocentesis is an invasive method of obtaining fetal blood from umbilical cord using transabdominal approach. This method, first described in 1983 by Defoe and co-workers, offers advantage in efficacy and safety over the fetoscopic methods previously used to obtain fetal blood and nowadays almost completely abandoned. The main target for obtaining fetal blood is the umbilical vein. Other possible targets for fetal blood sampling are fetal heart ventricles and the intrahepatic tract of the umbilical vein. Depending on the indication, chordocentesis can be performed from about 18 completed weeks of gestation until the end of the pregnancy. When imaging and placental conditions are optimal, it can be done as early as 15 completed weeks. It is usually performed on an ambulatory basis. It requires a high-resolution ultrasound scanner, an experienced team, and a laboratory specializing in fetal blood analysis. The most favorable puncture site is the placental insertion of the umbilical cord, as the cord is least mobile at that location. Blood is drawn from the umbilical vein with a 1 ml syringe. Blood samples must be immediately examined to identify purity of the sample, and the results of the analysis can be significantly altered in case it has been contaminated by maternal blood or amniotic fluid. A free loop of umbilical cord or the fetal insertion of the cord can also be used for puncture. Fetal heart is an alternative sampling site, and this technique can be used when access to the fetal circulation must be obtained at gestational age less than 17 to 18 weeks gestation, or if an emergency blood transfusion is required. Fourth one is fetal blood and tissue sampling. Fetal blood samples can be obtained directly from the umbilical cord under ultrasound guidance. Blood sampling enables rapid fetal karyotyping in cases presenting late in the second trimester. Indications for fetal blood sampling to diagnose genetic disorders are decreasing with the increased application of DNA analysis performed on chorionic villus material. Fetal skin biopsy has proved effective in the prenatal diagnosis of certain skin disorders, and fetal liver biopsy has been performed for diagnosis of Ornithine transcarbamylase OTC deficiency. Again, the need for tissue biopsy is now largely replaced by DNA analysis on chorionic villus material, and fetoscopy for direct visualization of the fetus has been replaced by ultrasonography. Coming to our last objective, that is to study about the preimplantation genetic diagnosis. Preimplantation embryo biopsy is now technically feasible for some genetic disorders and available in a few specialized centers. In this method, in vitro fertilization and embryo culture is followed by biopsy of 1 or 2 outer embryonal cells at the 6 to 10 cell stage of development. DNA analysis of a single cell or chromosomal analysis by in situ hybridization is performed so that only embryos free of a particular gene defect are reimplanted. An average IVF cycle may produce 10 to 15 eggs, of which 5 or 6 develop to the stage where biopsy is possible. The reported rate of pregnancy is about 20% per cycle, and confirmatory genetic testing by chorionic villus biopsy or amniocentesis is recommended for established pregnancies. This method may be more acceptable to some couples than other forms of prenatal diagnosis, but has a very limited availability. Dear students, this brings us to end the lecture on prenatal diagnosis. Hope you have enjoyed. Have a nice day.